Great. Well, as everybody is let in, everybody joins. Thank you very much for joining us for this ACS Virtual Journal Club. My name is Eric White. I'm joined with Dr. Chris Clifta, as you know, and the topic tonight is instability, particularly focusing on different bone block procedures and some of the innovations that are surrounding them. We're particularly honored tonight because this is a group of very engaging and very innovative thought leaders. Doctors Ian Lowe, Grant Garrigues, and Michael Bryan are going to sort of guide us through and teach us all about one of the more exciting areas in shoulder surgery, and something that I think all of us have a interest in, not only knowing what's currently out there, but also where the future is heading in this cool area. So I'm really excited about this. Chris, you have anything you want to say before you introduce our sponsor?
Yeah, I think this is an international panel, right, Ian? Maybe,
Oh,
potentially. Canada?
I think we're the 51st state now, actually.
Congratulations.
Welcome. If any of the attendees have any questions, post them in the chat, and we'll make sure to get these to the panelists.
Perfect. So word from Smith & Nephew, and then we'll get started.
President of Shoulder Marketing and Sales at Smith & Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Awesome. Fantastic. Well, let's go ahead and get started. So we are going to lead this off with the article focusing on the actual arthroscopic ladder J, and then we'll transition to the other articles. I'm going to give a quick summary, and then we'll open it up to our panelists. So this is a article from Pascal Boulot reporting on long-term outcomes of arthroscopic ladder J using a cortical button. 40 patients from the single surgeon. The mean age was 26, and a high number of them played sports. And the mean follow-up, although minimum was 5 years, the mean follow-up was 71 months. So he did have 3 recurrences, about 7.5% rate, and about 2.5% revision rate, or 1 revision surgery. But in general, people got back to full range of motion, including external rotation. The return to sport was very high, 95%, and good patient-reported outcome measures. The interesting part of this was the lysis. So he had partial lysis in 41%. And 19% overall had arthritis or early on arthritis. Kind of similar to, but even lower rates than some of the previous articles published on this. So really nice long-term study of the arthroscopic ladder J with the cortical button, showed it holds up. Although there is some osteolysis, as other studies have suggested, that it seems to not impact the outcomes. And a great short contribution to this evolving controversy on arthroscopic versus open, button versus screw. A lot of topics there that we could sort of take this. So why don't we sort of open this up? And Mike, so in your mind, when you're performing a ladder J, whether it's arthroscopically or open, what's your, for those that are just learning this procedure, those that are just beginning their career, what's the most important aspect of the ladder J? Is it what you use, the button versus the screws? Is it the position on the axial plane? Is it the sagittal plane position? Is it the whether you do it open scope? Like what do you think is the most important aspect of it? And what are some of the tips you have to get that?
Yeah, thanks, man. And thanks again for inviting us, all 3 of us to this. I think it's the graft position. And I think there's enough studies now that support whether you use screws or buttons, that the outcomes are similar. And there's some benefits to both, rigid fixation versus kind of the suspensory fixation. But I think getting to this procedure without the use of screws is attractive since the hardware seems to cause problems in a lot of series. I think the key, whether you do it open or arthroscopic, is the graft position. And I still do it open. And part of that is, and I've heard people say that the N is 25 to get like facile with this arthroscopically. And I average maybe 12 to 15 Latarjets a year, that I don't really want to take 2 years getting comfortable with an arthroscopic procedure when I think I do it well open right now, but it's still one of those surgeries that I still get worried about ahead of time because there's so many complications and dangers. And I still watch like the Jill Walsh video of a nice, beautiful open Latarjet ahead of time. So I think graft position, getting the graft low enough and making sure your graft is not proud. And then getting there, whether open or arthroscopic, knowing your anatomy and knowing where the danger zone is to try and avoid that neurovascular injury.
It makes me happy that, Mike, you still watch videos too. I kind of sneak away from the residents to pretend like I actually don't have to do, but I do. Anyway, Ian, you're doing some really nice work on screws versus buttons. What are your thoughts on screws versus buttons for Latarjets or DTAs?
Okay, we leave that point though, I totally agree with what Mike was saying, but to get the graft position perfectly, it's all about exposure.
Yeah.
Because I think people put the graft incorrectly because they can't see. They can't exactly see the joint line. Especially if you're doing it open, like the upper subscap just draping across you, and you can't lift it up. You can't see. It's the poor exposure that leads to the poor graft positioning. And so I think it starts from the very, very beginning, getting that exposure clean, wide open. You can see the entire gland. You can see the enfos. You can see the exact line of the face of the glenoid. And I think then you can make sure the graft is in the perfect position and you have less complications with hardware, better healing, and all those things follow related to exposure. So, when I'm teaching this, teachers or whatever, residents or fellows, like, I know you can do it through a tiny little incision. Like, I totally know that. But, when you're first learning, it's okay. You can make a bigger incision. You can do all those types of things and really get that exposure first and then think about your graft.
Are you going to answer my question or what?
I also want to know, are we going to cover tips and tricks to get the exposure that Ian's talking about?
Yeah. So Ian, answer his question, and then Mike, give us your tips and tricks in getting a great exposure for that.
Okay, so my experience with screws versus buttons is actually related to distal tibia allograft. It's not related to Latarjet. And so I just want to preface that first. And so in generally speaking, with our double suture button fixation, we had very, very good clinical outcomes, only 2 failures out of like 50 patients or so. And then we watched the graft remodel over time. So we had CT scans at 0, 6 months, 2 years, and 5 years. So we watched these slowly evolve over time. And what we found was that there was a certain percentage of patients that looked good at 6 months, very well healed, but at 2 years, they had remodeled back to what we called back to subcritical bone loss. Okay. And we had about 16% of patients that happened to. And so we have now switched to screws just to see how that might be different. And so what we have noticed is that at 6 months, when we had about 40 patients, 20 in each group, that the healing rate is a little bit higher when you use screws, particularly when you look for fully healed versus just partially healed. There's just a lot more fully healed with the screws than with the buttons. The buttons had a more percentage of partially healed grafts. And it's the evolution of the partially healed graft, which is most interesting to me in the suture buttons, because some of those actually completely heal by 2 years and it looks perfect. And another, about 50% of them go on to non-healing. So I believe that preventing or maximizing healing at 6 months CT is like the most important thing because it's the evolution of the partial healing, which is unpredictable from what we can see.
Yeah, fair.
Have you seen, Ian, like with Ivan Wong's data that shows the graft will resorb a little bit back to kind of your premorbid state. So if you're putting in a supraphysiologic graft, it's going to resorb a little bit more. Have you seen that in your data with your screws?
Definitely. Yeah. So if you supersize your graft, it will generally over time resorb back to the normal glenoid size, the normal glenoid vault, for sure. Yeah. Yeah. And I don't think that's necessarily a fixation thing. You know, I'm not sure that really makes a difference when you have screws versus buttons. If it's probably just a natural phenomenon, you know, Wolff's Law.
Size matters.
I'm with Ian on that. I think it seems like we're kind of talking about ladder J and DTL at once, but while we're on the graph, if we're talking about allografts, if you look critically at all the studies on allograft and autograft, speaking specifically of like iliac crest autograft versus DTA, there's a higher resorption rate with the allografts, but the average graft size is much bigger before. So people, you know, you buy this big graft, it's expensive, you want to, you know, use that cadaver in the most sort of ethical way. So people like put a big honking graft on there. Whereas if you're exposing somebody's crest or their clavicle, you kind of have this little piece of bone. So I think there's a strong tendency to use a bigger graft when you're looking at this allograft, and that's not a good thing. It's going to resorb if you're using screws. The screws might be prominent. So would caution people about doing that. I know, you know, I've talked to Ivan a lot. He spends a lot of time, and I know I do it. I'm sure you guys do it too. Spend a lot of time looking at that CT, exactly how much bone am I going to want to replace, and really think that through, and don't just say, okay, it's 25 by 15 by 10 every time, boom. Like really try to think about how you're going to replace that bone defect.
Fully agree, Grant. And I think like, you know, we've all been there, I think, where we have that DTA, you can take as big of a piece as you want. But then if you're taking iliac crest or distal clavicle, you plan to take a piece, but then you might not have as much as you plan to take. So I think those autographs are a little bit smaller, at least for me.
Yeah, no, fascinating. Grant, also with Mike's comment about the doing arthroscopic and not having the number of cases to get through that learning curve, advice of you on why you took up arthroscopic ladder J, and then how you're able to get through your learning curve so it was safe for everyone.
Yeah. So I mean, I've done them all: arthroscopic, open, DTA, and I'm continually switching. You know, we always say we're treating people based on your last complication. You know, it's like, well, I kind of like, thankfully, knock on wood, I haven't had any major complications, but I've had things where like, I would have liked that better. That could have been a little bit smoother. You know, maybe I struggle with this step. So I'm constantly looking for the perfect solution. But I will say for the ladder J, I first saw that when I was visiting Pascal Willow in 2010. And I was like, I don't even know what I'm seeing here. Like, I had never heard of it. I don't even know if he'd published anything at that point. My mind was exploding. Like, what is going on here? And then started to see the publications. And then I read everything that Laurent and he wrote, tried it in cadavers, visited surgeons, including Paul Favorito, who's very facile with the technique. He gave me some surgical videos that I literally watched over and over again. Because I think if you're doing these arthroscopically, I mean, Ian mentioned open, the exposure is a big part. Arthroscopically, there's just so many steps, you know, and when you have an arthroscopic procedure and things are swelling and if you've got like 20 steps you got to do, it adds up, right? And so the key is being able to move efficiently through those steps. And then the last thing would be like to have a time limit. So when you do your first ones, I tell the patient, hey, I might have to bail to open. You're my first case, you know, and they're, you know, God bless those patients that I was very upfront with them, were willing to do it. And I said, okay, if I'm not at this step at this time, I am going to stop and open them up, right? And you have to be honest with that. But yeah, I think those are the keys. But I think it's like anything else, you know. There's pros and cons to all these, right? So allograft versus autograft, DTA versus ladder J. I know we'll talk more about that, but the key with the scope is it's so you can see exactly where that graft goes. You can get it perfectly lined up. You know exactly to a millimeter where that is, up, down, left, right. But the moving it, the dealing with it is like so much harder. So you can see well, it's just harder to deal with it. And then with open, it's hard. It's the opposite. You know, you can move it around, but once you put that graft in that little split, you kind of like, it's like, can I see it? I'm kind of feeling my finger. It's the exact opposite. So it's, you know, pick your poison.
Mike, how do you make the open more? How do you respond to that? How do you make the open better? How do you optimize your graft position when you're going through that small split and fighting the muscle and fighting the upper subscap, fighting the joint?
I think it's tips that, you know, we've all heard through lectures over the years. And I was not fortunate enough to spend time with any of the French surgeons, but I have a good friend down here, Matthew Williams, who's in Lafayette, Louisiana, and he spent a few months with Gilles Walsh. And he said like the keys start with the setup, you know, and so I think like I do it open. I keep them relatively flat. I only sit them up about 30 degrees. I put a bump under the medial scapula to make sure that I can level that scapula to help with my screw trajectory. And then it's a very vertical incision, which it's almost like a chest incision. So rather than an axillary incision, it's starting at the coracoid and going straight down, you know. So it's very, very medial incision, which looks funny the first time you do it, but it really helps you get that screw trajectory to stay hopefully pretty parallel to the joint line. And then I think it's being comfortable with the axillary nerve and knowing that you can make a pretty aggressive medial subscapularis split to get a big enough exposure. Putting a Steinman pin under your upper subscap to lever that up, and then like a small bent Homan under the glenoid at 90 degrees to try and give you as much exposure as possible. But I think it starts with the setup and the incision.
All right, awesome. So we'll go on to the next paper. The first comment we had in the chat was from Peter Chalmers asking me to be nicer to Ian Lowe, and I will not. I will not do that, Peter Chalmers. I love you, but I will not. All right, so the next paper is, the title is Clinical and Radiographic Outcomes of Primary versus Revision Arthroscopic Anatomic Glenoid Reconstructions with Distal Tibial Allograft for Anterior Shoulder Instability Bone Loss. The purpose of the study was to assess the clinical and radiographic outcomes of arthroscopic anatomic glenoid reconstructions versus primary and revision surgery for addressing anterior shoulder instability bone loss. This was a retrospective review of patients who underwent arthroscopic anatomic glenoid reconstruction for anterior shoulder instability. Exclusion criteria included incomplete PROs, MDI, glenoid fractures, non-rigid fixation, and concomitant humeral avulsions, glenohumeral ligament or rotator cuff repairs. Outcomes consist of WOSI scores, DASH, complications, recurrence, and CT evaluations of graft position, resorption, healing. There were a total of 73 patients included. The primary group had significantly better outcomes than the revision group. The complication rate was about 10% in the primary group versus 24% in the revision group. There was no significant difference in graft placement healing rates between the groups. And the study concluded that there is worse results in the revision group than the primary group, mainly in PROs, with no difference in recurrence rate. So, Dr. McDonald, thank you for joining us today, guest appearance. What do you think? Should we be doing DTAs as primary procedures for everyone? Any role for labral repairs anymore?
I mean, as you know, I'm a big remplissage guy, so I don't do a ton of DTAs. I do some. My cutoff is 15%. I know the other guys, Ivan Wong's down to 10% bone loss, where he's converted into a bony procedure. I think that the bone procedures, well, some of these guys on the panel here are quite good at it. It's not without complications. Talk about bone resorptions, talk about screw problems, late degenerative arthritis, who knows about that? So I just think if I can do a good labral repair with a remplissage, I'd rather do that. It's lower complication rate, better outcomes in my hands.
Oh, fantastic. So when you are doing a bone procedure, what's your preference? So you mentioned the anatomic, so the DTA. Are you doing lateral J's anymore? Has that gone out the window at this point?
No, I think like if I have a high-end athlete, I'm still not confident enough in my DTAs to go to that. I'm going to do an open lateral J, my kind of tried and true operation. But I am kind of I would say I'm on the learning curve for DTAs still. I'm getting better. I use the bone block cerclage technique from Arthrex, which is not screws and it's not buttons either. So I know that the mechanics of that are not perfect, but I think it's probably better fixation than buttons. And then you get rid of the problems with the screws. So
fascinating. Grant, what about your, you said you've tried a lot of different things, and I know you're an expert at arthroplasty at this point, but what's your thoughts on DTAs? What's the role of DTA? When do you do it? How do you fix it?
Yeah, so I mean, since moving to my current practice, DTAs are a big part of the kind of rush culture here, and I was like, I got to learn this. This looks really cool. So and then interacting with Ivan and seeing his data, and basically I was in a lot of debates where I was like the arthro ladder J guy and he was like the AAGR guy. And then over the years, he kind of convinced me, I got to try that out. So I think the advantages of the DTA arthroscopically are you don't have to dissect, you don't do the subscap split. So you don't, if you use the Halifax portal, or certainly if you use buttons or screws, either way, you don't have to find the nerve, you don't have to do the subscap split. And that is the most challenging part of the arthroscopic ladder J. So you've taken that completely off the table. I think, plus the data that the sling effect, may not be the be all and end all. And I think you have a paper that we're going to talk about that speaks to that. But I think that the one thing that people don't realize about DTAs, either arthroscopic or open, is when you're doing a DTA, the conjoint is still there, right? And if the coracoid hooks over, those can really make it hard to get that parallel screw trajectory. People don't talk about that a lot. So just one little technical portal, open or arthroscopic, really release that clavipectoral fascia like very distally, so you can get that conjoint tendon over, maybe even bring the arm a little bit forward to like relax that tendon, because with a ladder J, it's really not a big deal to get that straight on. I mean, not a big deal, but it's a little bit easier, I think, to get the straight on view because you don't have the conjoint. With the conjoint there, it's like just one more thing in your way in what is already a pretty kind of deep hole you're working in.
Yeah, fantastic. And how do you optimize that? I mean, that is one of the more challenging aspects. The conjoint, as well as your graft positioning can be challenging, especially if you're not doing the subscap split, getting it down low enough. How are you optimizing those?
And how do you also deliver the graft? For people who don't do a lot of these, sometimes the hardest part is actually getting graft arthroscopically in. What's your tips for that?
Okay, so when I deliver the graft, I mean, you have to do a huge, rotator interval excision, and you establish a portal. But I actually use a 30 cc split syringe. So you actually, just get a syringe, cut the top off, split it down the length, and I put it on a, like we call it the silver bullet, but it's basically a large cannula. And we use that and we drive it in. And so we use that both if we're using, buttons or with screws. Because, when you're putting in it with screws, you have to put it in the hard way, the wide way, the 25 mm way. And so when you put it through the 30 cc syringe, because it's split, it will just expand and you can slide it right down into the interval. And so you can get past your pec and your conjoint and all those things, assuming you've established that already, with the Halifax portal. You want to put in your, half pipes, and you follow everything along and expand that on. When I use the wedge, so I use the wedge to make sure I can get my subscap inferior enough. And I hook the wedge on the very bottom part of the glenoid neck, and I lever that whole thing down. And when you're levering that down, I look back on the coracoid to see if there are any further adhesions there. And I release all that stuff just in case I've missed anything. I totally agree with Grant that getting that conjoint medial is super important. Otherwise, you can't get your alpha angle down flat enough, and your screw trajectory is going to be too oblique. And so I do a lot of the tricks that Grant just said, a little bit forward flex. Sometimes we flex the elbow. It takes, honestly, a lot of hands, in my experience anyways, because my whole deal is I hold the graft positioning. Somebody else is holding, is drilling, and somebody is basically position the arm exactly where I want it. And it changes, because sometimes actually, if you distract the joint a little bit so you can see the joint better, it actually tensions the subscap and you can't get it low enough. So sometimes you actually have to get the graft positioning, pin it there, and then look. And so those things you kind of all have to do. Those are some of the tricks anyways. Yeah.
Well, that's fantastic, Mike. Is there a role for DTA with you? And we've talked about some of the ways you optimize this. Don't make it too big, getting it down low enough, and getting the exposure. What's your thoughts on allograft to begin with, or DTAs, and then what's your thoughts on optimizing?
Yeah, I think I'm still kind of like Dr. McDonald, where if there's a bone loss case, my go-to is still ladder J. And with all of the compelling data, I'm thinking more and more, should I be doing primary DTAs? Usually, my experience with DTAs is in revision setting, maybe with a failed ladder J or a failed previous bone block, or posterior instability. And so my go-to with anterior bone loss has still been the ladder J, and then DTA in the setting of revision or failure. And I have more experience with doing DTAs open with screws, I've done some arthroscopic with buttons. I have not mastered Ivan's Halifax portal yet, so I don't have a ton of experience with that one. So I think in my limited experience with arthroscopic DTAs, just as Grant and Ian said, it's all about exposure. And I think getting a big release, taking out that rotator interval capsule, making sure you can mobilize your conjoint tendon, and then getting a big enough release on the labrum far enough down to 6 o'clock so you can get that bone graft in there so it doesn't get held up on the anterior labrum.
It's awesome. And I know we've been talking about bone block, but real quick, when do you do a ladder J then? Or when do you do, what do you consider bone block, a bone loss case enough that a Bankart remplissage won't take care of it?
Yeah, for me, it's similar to Dr. McDonald's data because I'm still a big believer in remplissage. So if they have 15% or less glenoid bone loss, primary surgery, I'm probably going to err on doing I'm going to lean towards doing an arthroscopic Bankart plus remplissage. Now, the area where I might not is if it's potentially a wrestler or maybe a rugby player. And then even in a wrestler, I might do a primary open Bankart. I start thinking more bone graft once I start approaching that 20% glenoid bone loss, which, as we all know, it can be difficult to measure. So 18, 19, 20%, then I'm probably thinking for me, ladder J. 15% or less, I'm most likely going to do a Bankart plus remplissage.
Yeah, a question from the audience is from Peter Chalmers again. Peter, thanks for asking this. Maybe Dr. McDonald, he wanted to know, what is the difference between neurologic risk in your hands between a DTA and a ladder J?
DTA and a ladder J. Well, DTA, I would say an arthroscopic procedure, I think, has a lower risk if you're using the Halifax portal, as long as you're paying attention to landmarks, staying lateral to conjoint tendon above the subscapularis. I think the risk is very low. As we know, there's data out there on ladder J, and including JP Warner's data, where you get changes in nerve conduction intra-op, but I haven't had any clinically significant nerve injuries, knock on wood, from a ladder J. I'm not sure the rest of the panel has. Maybe you can go around, but I also have a case next week. I'm going to do a high-level hockey player with 5% bone loss, so less than 10, a decent-sized Hill Sachs, maybe 1 centimeter by 1 centimeter. What would everybody do with that guy? This guy's going to play in the NHL in a few years.
Yeah, why don't we go around? So,
Hey, Grant, what do you think?
For me, the activity level or the activity is key. And so if it's a contact sport, I would lean towards ladder J in that patient.
Ian?
Sorry, what was it presented? Was it 10%?
Less than 10%.
Oh, come on, Pete. You can make that 10, right? I mean,
Actually, it said the radiology says 0, but there must be some bone loss.
honestly,
He's had two dislocations.
So 0. I mean, is there a piece of bone or no bone?
There's no appreciable glenoid bone loss, but there's a decent Hill Sachs.
honestly, I probably would lean toward a ladder J.
I figured you'd say that.
Mike, what are you?
I would do an arthroscopic Bankart remplissage. I think it's hard for me to remove bone to do a ladder J, and maybe the data supports longevity of the ladder J, but I mean, looking at Peter's data, Bankart remplissage with minimal glenoid bone loss, that's what I would do.
Peter, are you following your data, or are you?
Yeah, no, I'm going to do what Mike says. I have a little bit of trepidation because he's going to go out and bash around for the rest of his life, but we'll see what happens.
Those are tough though, where they have the big, large. This isn't a huge Hill Sachs, but still a sizable Hill Sachs.
Yeah.
Without a big glenoid load. Those are the ones where it's a little bit. I mean, a lot of those are in seizure patients, right? Because I think they dislocate and then they just keep chronically, banging that in, and that is a one where the algorithm. I've seen Ian Lowe's algorithm. It's very expansive, so you probably have a tree for that. But when do you get to like massive? Again, this isn't a massive Hill Sachs, but when they have a kind of an isolated Hill Sachs.
Well, the other thing we can get into
contact athlete.
For a bigger argument is the position of the Hill Sachs, whether it goes below the equator, whether it's anterior, posterior. So there's all those other things to consider too, which I don't know what significance to hold to those.
Testing. Ian, you admit, raise your hand. Do you have anything else to add, or ready to move on?
Well, I was going to say, like, my thought process has changed quite a bit related to minimal bone loss. Because, I think if there's like significant bone loss, 15, 20%, to me, that's a DTA. But now, particularly in revision settings or patients with minimal bone loss, where I'm still worried that a Bankart remplissage will not hold up, that's actually my indication now for ladder J. So on the lower degrees, even though I know people are like, no, that's totally wrong. The lower degrees of bone loss, because I'm like, okay, because if you do a DTA in those situations, you only have 1 or 2 millimeters of bone loss. That thing is just going to completely resort back to its native state, right? And so to me, that doesn't really make a lot of sense. And so I'm just begging and hoping that my lattice J will heal and my conjoint tendon will save me.
I
Dr.
wonder if we should be doing more open Bankarts, An and Murthy and Brian Wolf
Yeah.
really advocate for that. If you do
Yeah,
an open Bankart
Bob
with a nice
Arciero.
capsular shift, less than 10% failure rate, and you're not changing the
okay.
anatomy.
So, all right. So what what is so magic about, is it okay? So someone who subscribes to that, which is, I'm not the person to be the apologist for that. Explain to me what it is about cutting through the skin and doing the Delta Pack and doing either a subscap tape down or subscap split. Is it more scar tissue? Is it that you think you get a better repair? Is it you're using different techniques? Like, why is it better open versus
I
endoscopic? I
think,
just
Grant,
want to hear the argument.
that's a great question, but if you get Bob Arciero to show you a video of his technique, it's not just a Bankart. He throws in a capsular shift, so it's a combined. It's kind of like a Carter Rowe description of the Bankart. So it's not just fixing the labrum, and I think that's where the difference is.
So is he like imbricating the capsule in some way, or
imbricates the capsule at the same time?
I think so too. If you're going to do a true capsular shift, and you're elevating the subscapularis off the capsule and you're fixing your Bankart, but then you're doing kind of a humeral based capsular shift where you're doing pants over vest and you're decreasing that capsular redundancy. I also think that with an open Bankart, we can probably get bigger bites of the tissue. So when we're passing sutures, we're probably creating a bigger bumper. And then we're doing a capsular shift and getting that anterior scar tissue, Grant. I think it all contributes, but I think it's more than just fixing the labrum.
So you're doing more capsular work. So that is going to be great for your recurrence risk, but is that going to be so great for your range of motion?
Yeah, exactly.
According to our studies, there's no significant difference. So you probably wouldn't do it in a pitcher, but I think in a collision and contact athlete with, less than 10% bone loss, I think it's a good option in your hockey player, wrestler, stuff like that.
And I've seen some of Bob's videos, and Mike, you and I did them with John Finland, and it was beautiful. So
beautiful. Yeah.
I think, that's not part of my algorithm, but it's good to hear the argument that when you're doing it, you're probably getting a little more capsular work along with the open thing. I think that makes sense.
I know some people, that is their algorithm for the contact athlete with less than 10% bone loss. And it's not mine currently, but I'm just saying it's something we probably should keep in mind.
Real quick before we move on to the next article, Dr. Duralde, thank you for asking this question. He wants to go down the panel and he wants to know, is there a degree of bone loss that leads to you all offering a DTA over a ladder J? Do we have a number? Maybe start with you, Pete.
Yeah, I think that ladder J is probably good up to between 20 and 25% bone loss. Above that, you're going to have to look to an allograft because it's just not going to be enough.
Ian?
Yeah, agreed. Anything over 25%.
Grant?
I usually use 30, but also Emilio Calvo has a great study showing that if the size of the graft does not render your lesion back on track, i.e. if the coracoid is not big enough to put you back on track, it doesn't work. It's not as effective to use a ladder J. So for me, actually measure the coracoid, and if that's not going to make me on track, definitely tibia. Usually that ends up being about 25-30%.
Mike?
Exact same as Grant.
Awesome. Thank you, Dr. Duralde, for that question.
Awesome. All right, we'll move on to the next one. We kind of covered a lot of this, but this will probably play nicely into what we've been talking about. So this is the arthroscopic ladder J versus free bone block meta-analysis. So this is looking at a meta-analysis including anybody that has less than 2 years of follow-up, looking at over 5,000 procedures. So in the latter J, they looked at 908 cases, 18 studies. The bone block was 15 studies, 469 cases. So crazy amount of numbers included in this meta-analysis. Overall, similar demographics, similar rates of bone loss between the groups. And if you look at the recurrence and reoperations, very similar. So recurrence was 3.6 versus 3.8, reoperations 4 versus 4.9. And overall, similar complications, maybe slightly higher in the bone blocks than the LRJs, but nothing significant. And allograft versus autograft, it kind of was a wash for the most part. There were higher hardware complications with screw fixation versus the flexible fixation included. So really nice comparative study showing when you're dealing with this this arthroscopic bone block procedures, doing LRJ versus free bone blocks, whether it be iliac crest versus distal tibia, didn't seem to matter. Hardware flexible fixation didn't seem to have less hardware associated complications. And potentially the bone blocks had a little bit more overall rates of complications, but nothing was truly dramatic or maybe clinically relevant. So really nice contribution showing the difference between these. I think this kind of adds to the controversy we're still working out. We're still trying to evolve, and then adds in the arthroscopic flavor to it that was introduced a while ago, and maybe it's catching on, maybe it's not. It's kind of hard to say. So this kind of builds on what we've already been talking about with regards to the comparison between LARJ and the DTAs. But I guess as we move forward, like where are we going in the future? And maybe Dr. McDonald, if you want to lead this one off, are we moving away from LARJs? Is this the emergence of the bone blocks, and in the future we're going to be doing open or arthroscopic bone blocks, and LARJ will be a historical operation we talk about? Or is this something that we're going to be continuing to refine algorithms and having a little bit more refined data on when we do one versus other? How do you see this evolving?
Yeah, thanks. Great question. I can't see us doing LARJs. Well, not me, I'm old, but in 10 years, I think bone blocks, arthroscopic bone blocks will be so sophisticated. The fixation we'll figure out. It won't be screws. It'll be something else. It'll be something with a low complication rate. And I think that LARJ will become a historic operation just because it's non-anatomic and there's small risks associated with it. I just think we're going to be better at arthroscopic techniques in the future.
So Grant, I'm going to then throw this to you. The next one to you. Arthroscopic LARJ is harder than an arthroscopic bone block procedure, I think, as you kind of mentioned and talked about. So why is there a future for arthroscopic LARJ? Are we going to master the bone blocks eventually to the point where we don't need to be doing these? Or is the arthroscopic LARJ going to become technically easier and more people are going to be doing these? And maybe we'll shift back, then the pendulum will switch back.
Honestly, I don't know. I mean, I think it's hard to say. I mean, this is an area that is very quickly evolving within shoulder and sports medicine, of course. It's hard to say that we would have predicted we'd be here, now, say 10 years ago. I do think that I'm not sure that we can say we've seen the last of the LARJ. I mean, this is a tried and true operation that's worked, and it's going to be hard to kind of unseat the king, so to speak. But Dr. McDonald may be right. We'll see. I think as far as the arthroscopic bone blocks, I mean, the fact that it's we talked about allograft versus autograft. I mean, you've got living bone right there. The sling effect obviously is debatable, but I just think there's a lot of advantages to the LARJ. It's going to be hard to move completely away from that.
Awesome. Ian, why are we still having the debate of arthroscopic versus open? I mean, this is 5,000 plus procedures, low complication rate, matching the open procedure. We don't do open rotator cuff repairs very, very often anymore. I think very few people probably listening in have seen that. Why are we still having this debate? Why is this not taking off, this arthroscopic bone grafting procedure?
I don't know. I think I don't really understand that.
Well said.
Because honestly, I think a free bone block is not that much crazy harder than a Bankart remplissage. I think the jump to an arthroscopic Latarjet is quite large, but especially if you're using flexible fixation, I think the jump is not that difficult. And that also has just a lot less complications or potential complications. And so I think that the free bone block is really the transition. And I actually think what's going to happen is that I actually think the arthroscopic Latarjet is going to go away because you're going to be doing so few Latarjets. Because people will slowly transition and figure out that the free bone block arthroscopically is not that hard. So the majority of bone loss cases are they're going to actually treat with a free bone block. And then the number of Latarjets that do a year is going to drop in numbers. This is what happened to me. The number of Latarjets did a year kept dropping and dropping. And now I do no more than 1 or 2 a year. Well, if you're doing 1 or 2 a year, you're not going to do that arthroscopically. Well, this is just me. This is what I,
Ian,
yeah.
sorry, just speak to that. I mean, I think the companies and, you know, whether they're promoting their instrumentation for a free bone block versus Latarjet, I think we've seen a trend across the medical device companies to speaking, teaching, promoting their use more for free bone block. So I think that speaks to where the market, so to speak, is going
Yeah.
towards the free bone block, certainly.
And I think it's just because it's a little bit easier. Like, you know, if you talk to a lot of, I'm not trying to be offensive, a lot of the people who have visited Pascal Boileau spent time with him, watched him in the OR, tried to learn, worked in the cadaver. What percentage of them actually routinely do arthroscopic Latarjet? It's a very small subset of people who actually took it on and thought this is something I can do. So even though he does it amazing, you do it amazingly, Eric does it amazingly, like a lot of people can do like it, it's still a very difficult procedure and you have to be completely dedicated to the process.
We got a question from Dr. Abrams. Maybe Mike, you could field this. He said failure can be seen with large Hill-Sachs lesions with these procedures. When and who do you graft with a large Hill-Sachs lesion? And thank you, Dr. Abrams, for that question. And Mike, good luck.
Yeah, great.
I'm going to stick with our current line of answers and say we don't know. And so I know that Dr. Abrams believes very strongly that, you know, the Hill-Sachs defect is going to be part of the next frontier in bone grafting. And there's a couple surgeons that are working on kind of arthroscopic bone graft of the Hill-Sachs defects. And I think Scott Trenhill has done a fair number of those. Ian's done some of those. So I think that's going to be part of it. And I mean, I guess in those lines, I agree with Dr. McDonald that I think things are going to progress to more and more specific arthroscopic techniques to deal with bone loss. And as we tease these numbers out more, we're going to be bone grafting for the 9 and 10% glenoid bone loss. And then maybe we'll be bone grafting on the Hill-Sachs side too, because I think Dr. Abrams believes that that has been ignored until the last couple of years, really. And because we've been so focused on the glenoid side, we haven't paid as much attention to the Hill-Sachs side, the humeral side. And so I think we're going to be seeing more and more of that. So I think the future probably is in more arthroscopic techniques, but I totally agree with Grant that it's going to be hard to unseat the king because Latarjet has such a strong track record. But you know, doing it arthroscopically, like Ian said, you got to be committed to it because it's a steep learning curve, and you have to really stick with it if you want to get good at it, like Ian and Grant and Eric.
Hey, Ian, you're gonna make a comment?
I want to ask a question to Dr. McDonald, since I know he's the king of the remplissage. Is there a lesion that you think is too big to remplissage and you believe needs to be bone grafted?
Yeah, good question. The answer is yes. I don't know the exact size, but I'd say 25% or greater, it's too much.
Okay.
And I start thinking about a humeral head graft. And I think that, you know, the discussion here is great. I think Jeff Abrams has a great point that we kind of ignore the bone grafting on the humeral side. And that could be the answer. I remember Tony Miniacci's original series where he bone grafted the humeral side and he had 0% redislocation rate. So we just have to perfect that technique arthroscopically and make it easy and simple. And one of the reasons I think things will evolve to arthroscopic free grafts is it's going to be just the same reason we don't do a lot of open Bankarts now is because, well, the old guys like me, we grew up on it, but the trainees now, if you ask my fellows and my residents to do an open Bankart, they have no clue, like they've never even seen it. So I think that the same thing happens more and more free bone grafts we do. It's going to be what we're teaching, what the trainees are going to see, and they're going to perpetuate that.
Yeah. Yeah, no, fantastic. The fascinating to see where we're potentially going, you know, and with the ladder J, if you can figure out that subscap split arthroscopically, I feel like that's maybe what will bump the needle back in the other direction, but I don't know if that'll ever be totally figured out. Why don't we go on to the last article and then switching gears, unless anybody else has anything else to add on anterior bone block procedures.
Eric, could I ask a question? I was
Yeah.
just curious for you and Grant and Ian, what is your current algorithm for when you would do arthroscopic ladder J and when you would do a primary arthroscopic DTA? What makes the difference in your mind?
Ian, you kind of hinted at this before, but do you want to take it?
Sure. I mean, I already talked about the patient with kind of minimal bone loss. And the only other patient is when the patient comes in and asks for ladder J. So it's very hard for me, you know, they'll come in. Oh, I had a failed banker. My buddy had a ladder J. I want a ladder J too. I'm like, okay, you're getting a ladder J. I'm not going to argue with him and try to argument out of it to get a DTA. I give the man what he wants.
Love it.
Grant, what about you?
Yeah, so for me, we talked about if the lesion's too big, that's an indication for DTA. I think, you know, I'm doing a lot of mine. I'm doing a lot of open lateral J right now. I'm using the same arthroscopic instrumentation. And part of that is, you know, I do a lot of mine in a surgery center. If I'm going to pre-cert, it's so ridiculous, but if I'm going to pre-cert this as a 29999, then I'm going to have to battle with this insurance company for weeks before the Canadians have no idea what I'm talking about right now, but I'm going to battle with them just to get the approval for the surgery. Whereas open ladder J has an existing code, I can just do it. So, and then on the back end, you know, you don't get paid anything extra for the arthroscopic ladder J, and you got the extra price of the tubing and the burrs and the other stuff with it. So I'm a big fan of arthroscopic procedures, but it ends up being it's a little more costly. It takes a little bit longer. It's more administrative headache for me. So unless there's a compelling reason to do it arthroscopically, I've been doing a lot of mine open, and the patients love them.
Yeah, no, that's perfect. I mean,
Eric, how about you?
Considering DTAs, it's the size, so about 25% is when I start worrying about J. I also think the bipolar, the seizure patients where you're doing bipolar grafts, obviously, you do DTA in that same. But anything else anybody wants to talk about the anterior bone loss before going on to poster? All right, Clifton, why don't we go on to poster?
All right, so the title of this one was Acceptable Long-Term Outcomes of Arthroscopic Bone Grafting for Current Posterior Shoulder Instability, Minimal Follow-up of 5 years. The purpose of the study was to examine the long-term outcomes associated with arthroscopically placed iliac crest bone graft for recurrent posterior shoulder instability. All patients study had a minimum 5-year follow-up. All patients had PROs, including ASES scores and other standard PROs. There were a total of 18 patients that were included. Pain levels decreased, PROs increased in all patients. 37% of patients had reoperation for symptomatic hardware. 4 patients had posterior apprehension with testing. So this paper concluded that arthroscopic posterior iliac grafts for recurrent instability demonstrate effectiveness to decrease recurrence and increase patient satisfaction. There was a high rate of screw rotation, which required removal of hardware of 37%. First is a comment, Eric, you were an author on this. What the hell were you doing on these patients where you had 37% complication for hardware? And 2, Ian, why do patients have more hardware complications with posterior bone graft versus anterior?
So to start out with, none of these are my patients, but but I did help Florent write this up. So yes, but and second, I mean bone graft, posterior bone grafting is a bit different. And truthfully, like posterior bone loss is a whole different topic, or whole posterior instability, a whole different topic. We still are trying to understand it. Our understanding of that is so much less than anterior, and so the question about the more complications probably also deals with the question of indications for procedure, about you know, when you're doing retroversion, actual true bone loss, etc., India, that type of stuff. So I don't know, Aylin, do you want to take that?
Eric, come on. I totally agree with Eric. I think our understanding posteriorly is purely in its infancy. honestly, the surgery we do posterior with posterior bone grafts, it's fraught with complications, fraught with hardware complications, fraught with osteolysis, fraught with horrible arthritis. Um, and so I think it's also because we do so much fewer cases.
Yeah.
We just don't do as many, so we can't even get good at this operation. When a guy like Laurent Lafosse only has, like 19 patients or whatever it was at 5 years, it's like, it's telling you something, man. It's telling you something. So, and I think there's a lot of soft tissue anatomy, and I know Eric, you've been doing a lot of, information on, looking at the lat dorsi and stuff like that, and see how that affects things. And these things we don't understand. At least I don't understand them that well. And how does that affect posterior instability? Man, it's a black box. That's why I love that topic, because we're just really not very intelligent with it.
Totally agree. And I think we hardly even started looking at like degrees of posterior bone loss until recently, a couple years, And so I think we would just fix it arthroscopically and then, oh, I wonder why that failed. And then start looking back and realize, holy moly, there's 13, 15% posterior glenoid bone loss, or maybe it's related to the acromion morphology. And you know what really struck me about this article was like the PROs were similar to like what we would see for revision anterior bone blocks, right? Like the postoperative outcome measures are not great, which again tells you, like Ian said, that we have not quite figured this out.
For
I
sure.
think furthermore, it's like I I mean maybe this is a hot take, but I feel like posterior bone block, I think for me is easier than anterior bone block in many ways. I mean, you just don't want to get too medial on the spinal going a notch, but as far and you want to make kind of a pretty sizable, split through your rotator cuff. But I find technically that maybe even a little more straightforward, though the complication rate's higher. So it's a little bit of a snake in the grass. You might think, oh, this is great. And I think that speaks to the fact that we don't really understand the pathology, what's going on, why are these people recurring? I think some of these are like, have maybe a little bit of retroversion. Maybe this is the, kind of the heading down the B0 pathway to arthritis, right? So I think a lot of people get lumped into posterior instability. But I think technically, and again, maybe I think this one's a little bit easier actually than the anterior one, which is just makes it all the more confusing to me.
Yeah, I mean, I would agree with that as well. It's so much easier. I mean, compared to arthroplasty, I do think the technical learning curve is much less. But that being said, the complications aren't necessarily so. So Dr. McDonald, how is this going to evolve? And what's your take on posterior bone block? I mean, one of the masters of the arthroscopic lateral J, published this study showing that there's clearly a mortality with this, and there's clearly morbidity with this procedure. What is your experience with this? How do we get better? Maybe, how do we better understand the scapular relationship with the, with the retroversion, with bone loss, with everything else that's going on to these patients?
Well, I think one of the reasons we don't understand it very well is because these cases are rare. Like posterior instability is a lot less common than anterior instability. And posterior instability, most of the time, you fix the posterior Bankart and they're fine, right? So it's rare that you have this situation where you have a failed posterior soft tissue operation with bone loss and you have to revert to a bony operation. So if something is rare like this, then it's hard to get good at the solution for it. So I think that's our issue. And there's a lot of factors at play. And I think we just have to kind of tease through larger series, pool our data, and try and figure this out.
This came up in a previous journal club. It was asked, when you see a patient that's starting to have posterior translation of the humeral head without any real arthritis, and these often fail with labral pairs posteriorly, is there a role for DTAs or a bony block procedure when you see that? How do you correct that posterior translation if it starts?
Yeah, let's and go even further. So the first part is, can you correct if there's no or very minimal retroversion? And the second part is, let's say you have a young patient with some retroversion but no arthritis. What do you do for that?
Yeah, I think those are really difficult cases. I think once you get it's kind of an early B2 glenoid where that head is sublux posterior and is eccentrically wearing on the glenoid. And then you're kind of doomed once you get to that situation because you get chondral loss, you get a glad lesion, and nothing I've been able to do has been able to reverse that.
I agree. I think that's one thing that makes it so tricky where kind of like Grant said, that it's the B0 glenoid, and that they're started down this natural history that we have no ability to alter or stop, whether we do a soft tissue procedure or a bony procedure. And I think there's some successful case reports of doing a posterior bone block that does well, but I still don't think that we're changing the natural history of that shoulder, because it seems like it's headed to the progression of arthritis. And at least our current techniques, I think, are not changing that natural history.
So the patients, that 35-year-old patient sitting in your office and saying, "Man, like my shoulder's not feeling the best. Like, what do I do? What do I do with it? You've made me do therapy for 2 years now. You've injected it this multiple times. It's not going there. What am I doing with my shoulder?"
Eric, the
That's the
only
one that
exception I would say, oh, sorry, go ahead, Mike.
I was just going to say that's the one where right now I'm offering an arthroscopic DTA, but I tell them, I try and be very honest with them and say this might not change the natural history of your shoulder. And in less than 10 years, you still might need some sort of an arthroplasty. What do you think, Grant?
Yeah, I agree. I think the only exception for me would be patients that have a tight anterior inferior capsule. I do think that our data and data of others have shown that in some subset of these posterior subluxation cases, tight anterior capsule causes obligate posterior translation. And so we don't have a lot of data on, we know that is an association. We know that the anterior capsule is pathologically thickened and contracted. What we don't know is the next step of if you go in and release that or do some early release, will that prevent the progression of arthritis? We don't have data for that. I have gone in and done that on patients where there's some other issue. Hey, they have a labral tear posteriorly with some subluxation. Hey, and there's stiff and external rotation. I'll go in and fix the posterior labrum and do an aggressive rotator animal and anterior release. I hope that changes the natural history. I also talk to patients about non-operative treatment. Hey, stretch out that anterior capsule. So just keep that in mind. If you have the patient with that constellation of symptoms, posterior subluxation, but also anterior capsular tightness, and that may be something that you can do to try to address things.
Fascinating. And Ian, are you what's your thoughts on this? Is the DTA gonna solve this problem? Are we gonna get better at shaping that and fitting it perfectly to anatomically rebuild the posterior glenoid, or how are you approaching these patients?
Yeah, I mean, I have the same philosophy as Mike. I'll offer it to them, but I'm really kind of negative about the mid and long-term results. And a lot of times that negatively makes them choose not to have surgery, actually, which is, I find interesting. But I also think that this is part of our problem because we're lumping all these patients together as in posterior bone blocks. The B0 glenoid is completely different to your Ehlers Danlos patient, which is completely different to your voluntary, subluxar dislocator. And we're all just kind of looping all these people together. These are posterior bone block patients. Well, they're not. They're all completely different with completely original diagnosis. And we need to separate all those diagnoses out before we can figure anything out.
Yeah.
Before we can figure out if you should be doing a tendon transfer or should you be doing a bone block or should we, you know what I mean? So that's part of our problem because we have so few cases. We bunch all the posterior bone block cases together, but really we need to separate them by diagnosis. Anyway,
Sure.
that's
Hey, Grant,
just
so Rick Ryu has a quick question. He says, what is the acromial tilt and height in these early subtle posterior subluxation cases? How does that affect the natural history?
Who's the question from? Was that?
Rick Ryu.
Oh, perfect. Yeah. So, hey, Rick. So yeah, so that's a lot of Christian Gerber and the bloggers group have looked at the acromial tilt and height, and basically the idea being that, similar to the work that they really started with the critical shoulder angle and kind of looking at the vectors of the acromion in that plane. Posteriorly, if you have the acromion tilted, it's going to kind of pull the delta is going to pull the humerus back in a different way. That's something that I haven't analyzed personally in my patients, but his data is really compelling. I also haven't taken any steps to change the acromial morphology, but very much interested in that data and how that pans out. Again, I think with a critical shoulder angle, they really put some new concepts on the map, and I think this acromial tilt that the bloggers group is working on is just as fascinating.
Excellent. Well, thank you all. We're about to wrap up. Any last comments about posterior bone grafting or just bone grafting in general? Wonderful. Well, thank you very much for your incredible expertise. This was great. And this will be recorded and posted on the ASES website. So for those of you who couldn't attend or miss part of it, please go ahead and tune in. And thank you all very much for joining us. Chris, you want to end it?
No, it was an awesome group, and the conversation was great, and the banter was awesome. So thanks for the panelists for being here.
All right,
Thanks.
thanks
So much for having us.